Hello guys, now I'll be starting with chapter 71 of your Apurba Sastry Essentials of Microbiology, which is about bacterial meningitis. Now this is a very important topic as far as the whole of microbiology or CNS microbiology is concerned. इसके ऊपर मल्टीपल चॉइस क्वेश्चंस बहुत सारे बन सकते हैं एंड इट इज़ ऑल्सो एन इम्पॉर्टेंट केस फॉर योर यूनिवर्सिटी एग्जाम्स. Coming on to bacterial meningitis. Meningitis is a life-threatening infection of the leptomeninges, arachnoid and pyometer as discussed already, and also may involve the subarachnoid space. It is caused by bacteria, viruses, fungi or parasites. Bacterial meningitis causes the highest global burden. In this lecture, we'll be talking about acute bacterial and chronic bacterial meningitis. Let us start with acute bacterial or also known as the pyogenic meningitis. Acute purulent infection in the subarachnoid space is what is seen in acute bacterial meningitis, and CSF shows elevated neutrophils PMNLs. Okay, now common causative agents overall are Streptococcus pneumoniae in 50% of the cases, and Neisseria meningitidis in 25%, Streptococcus agalacti in 15%, and Listeria monocytogenes in 10%, and Haemophilus influenzae in less than 10% of the cases. In neonates, the common agents are Streptococcus agalacti, E. coli, Klebsiella, which is a gram-negative bacilli, and Listeria monocytogenes. In elderly patients, Streptococcus agalacti and Listeria monocytogenes are the common agents. Now coming on to the pathogenesis, the spread is by respiratory droplets, by coughing, sneezing, kissing or close living. The routes of entry, first being the hematogenous spread, it's the most common, via choroid plexus or blood vessels. Direct spread from infections near the meninges like otitis media or sinusitis, and anatomical defects like trauma, surgery, congenital CNS defects. All these can contribute to the entry of a pathogen which can cause acute bacterial meningitis. What are the predisposing factors? Age, neonate immature immunity, and birth canal exposure and leaky blood-brain barrier can lead to a predisposition for the disease. Vaccination, reduced incidence post HIV vaccine, and so HIV vaccine is a preventive for this. Primary respiratory infections like alcoholism, diabetes mellitus, immunosuppression, splenectomy. CSF shunts like entry of staph, Pseudomonas and Acinetobacter can occur from CSF shunts. The blood-brain barrier breach mechanisms, they are disrupted tight junctions, transport in phagocytes and transcytosis across the endothelial cells. All these can predispose for acute bacterial or the pyogenic meningitis. Now the clinical manifestations of the disease. Incubation is almost for 4 days, ranging 2 to 10 days. Symptoms are fever, vomiting, which is projectile in nature, headache, throbbing headache, and altered consciousness, and photophobia are the common symptoms seen in acute bacterial meningitis. Now, there are some signs which are clinically diagnosed for meningism. There is knuckle rigidity, resistance to passive neck flexion, so the neck is stiff. There is Kernick's sign, that is pain or resistance on knee extension with hip at 90 degrees Celsius, and there is Brudzinski sign in which neck flexion leads to spontaneous hip or knee flexion. In infants, there is slower onset of the disease with fever, irritability, bulging, fontanelles, and neck stiffness is not very commonly seen. Complications are meningoencephalitis, seizures, and raised intracranial pressure and stroke. Organism-specific meningococcal rash can occur in purpura. Okay, now lab diagnosis. Specimen collection, ideal specimen is the CSF and taken out by lumbar puncture. इसे 3 parts में divide किया जाता है for cell counting, biochemistry and bacteriology. We do not have to refrigerate CSF if culturing. Okay, and stored at 37 degrees Celsius. If delayed, then we have to freeze only for molecular testing because freezing often kills or makes them inactive, the bacteria. Now, our blood culture use Bactec or alert bottles, and for meningococcal meningitis we use nasopharyngeal swabs, rash scrapings, and transport in Stewart's medium and inoculate on Thayer-Martin or NYC medium. Now, what do we see in analysis, CSF analysis? For this is for all normal CSF, pyogenic CSF, tubercular CSF, and viral CSF. So the CSF pressure, normal CSF pressure is 50 to 150 millimeters of water. In pyogenic, it is highly increased, like more than 180. In tuberculous, it is increased, while in viral, it can or cannot be increased. Total leukocytes in normal condition is 0 to 5 per millimeter cube. In pyogenic are 100 to 10,000. In tubercular are 10 to 500, and in viral are 25 to 500 per mm cube. Now the cell types, normal cell types are lymphocytes. In pyogenic we see neutrophils, and tuberculous or viral meningitis we can see an increased number of lymphocytes per se. In glucose milligram per deciliter, we see in normal there is 40 to 70 milligrams per deciliter of glucose in CSF. In pyogenic, it is reduced because of uptake by the bacteria, less than 40 or maybe even absent. In tubercular, it is less than reduced 20 to 40, and in viral, it is unchanged. Now, what about protein? 15 to 45 milligrams per deciliter protein is the in pyogenic cases, it is more than 45, often more than 250. In tuberculous cases, it is 100 to 150, moderate to highly increased, and in viral cases, it is 20 to 80, almost normal or slightly increased. So these are the diagnostic points which help us differentiate between the pyogenic, tubercular, and viral meningitis. What are the key points to remember? The Streptococcus pneumoniae is most common overall. In neonates, Streptococcus agalacti, E. coli, and Listeria are the common agents. In diagnosis, we have to do CSF analysis plus culture, and classical signs are knuckle rigidity, Gernig's and Brudzinski sign, and purpuric rashes are seen in meningococcal meningitis. So all these are MCQ points. Okay, this we have already discussed in the agents. Streptococcus pneumoniae is the most common overall agent for bacterial meningitis. Now coming on to the diagnosis and laboratory clues. As we are seeing lab diagnosis. So now CSF microscopy or the gram staining shows gram staining appearance of a gram positive diplococci, flame or lanceolate shaped capsulated organism. This is a suggestive of Streptococcus pneumoniae, most common. A gram negative diplococci with lens or half moon shaped capsulated structure is Neisseria meningitidis. Pleomorphic gram-negative cocobacilli, which is capsulated, is Haemophilus influenzae. Gram-negative bacilli, a single, not in groups, is E. coli or maybe other gram-negative bacilli. Gram-positive cocci in short chains is suggestive of Streptococcus agalacti, and gram-positive short bacilli, diphtheroid-like, is suggestive of Listeria monocytogenes. Now, what are the CSF findings? WBC count is more than 1000 per microliter. Predominantly neutrophils are there, 90 to 95%. Proteins are elevated. Glucose is markedly decreased or absent, as we have discussed in that table. CSF pressure is highly elevated. An exception, Listeria may show lymphocytes. L for Listeria, L for lymphocytes. Gram staining में हमें क्या करना है? Gram staining helps in early empirical therapy. A heaped smear is made. Multiple CSF drops air dried one by one at the same spots to increase the sensitivity of gram staining is done, because CSF is very watery consistency, so we like to concentrate it by making a heaped smear. Okay, now centrifugation is done, which improves detection via cytospin method. Now antigen detection from CSF, latex agglutination test is done, which detects the capsular antigens of Streptococcus pneumoniae, agalacti, Neisseria meningitidis, Haemophilus influenzae, and E. coli. This is more sensitive than microscopy. Urine antigen test is done, ICT, immunochromatographic test for Streptococcus pneumoniae. This detects C. polysaccharide antigen. In culture techniques, we use enriched media like chocolate agar or blood agar, and differential media is McConkey agar. CSF inoculation, at bedside we have to inoculate it into blood culture bottles or BHI broth. And incubation 37 degrees Celsius, preferably in a candle jar with 5% CO2 is done. Now coming on to the identification of the three organisms, as we have discussed in that table. Streptococcus pneumoniae, we have discussed the morphology. It will show, and if grown on blood agar, Alpha hemolytic, Drotzman or Karam coin colonies will develop, and biochemically it's bile soluble, insulin fermenter, and optochin sensitive. About Neisseria, it grows as a non-hemolytic bacteria on blood agar, and in biochemical test it is catalase positive, oxidase positive, ferments glucose plus maltose, and in serogrouping we use SASG test using antisera. About Haemophilus influenzae, blood agar with Staphylococcus aureus shows satellitism of growth, and 10th and 5th factor grow only around the XV disk. Okay, so this is sensitive to 10th and 5th factor, so it grows around only on the 10th and 5th disk. Now Streptococcus agalacti on blood agar, it forms beta hemolytic colonies. In biochemical testing it shows CAMP test positive bacitracin resistant organisms, and in serogrouping it is Lancefield group B bacteria. Now gram negative bacilli, E. coli, Klebsiella. On McConkey agar, lactose fermenting colonies are formed. Identification is by ICUT test, indole citrate urease and TSI. Pseudomonas and Acinetobacter non-lactose fermenting colonies are formed. Pseudomonas shows oxidase positive reactions, while Acinetobacter is oxidase negative. Listeria monocytogenes, motility tumbling at 25 degrees Celsius. Tumbling motility seen in Listeria, not at 37 degrees Celsius. It is temperature dependent flagella activity is seen. About blood agar, beta hemolytic colonies are seen, and selective media is Palcam agar. Now, identification systems, as we have talked, conventional biochemical test can be used, or automated system like Malditov and Vitek can be used. Now, antimicrobial susceptibility testing is done for various organisms to detect कि ये किस एंटीबायोटिक के लिए सेंसिटिव हैं. So disk diffusion or automated MIC based Vitek is preferred, and cultures take more than 48 hours to develop and positive in 70 to 85% of the cases. Prior antibiotic use reduces the sensitivity obviously. Now we have some rapid diagnostic tools, like we have to use them when there is a delay or culture is negative. Molecular tests like highly sensitive, fast and help serogroup identification. Formats are multiplex PCR, real-time PCR, automated biofire film array detects 14 pathogens in 1 hour. We have to do gene targeting in some cases, like in Neisseria meningitis, CTRA and SODC gene. In pneumonia, LYTAN, PLY and PSA capital A gene, and in influenza, BEX capital A gene are identified. Now coming to the serology, ELISA is used to detect the anti-capsular antibody of Neisseria meningitis. It is useful for seroprevalence or vaccine studies but not for diagnosis. About the treatment, हम लोग empirical and definitive therapy देते हैं, like till when the culture report or the antibiotic susceptibility report comes, we give IV ceftriaxone or cefotaxime plus vancomycin, and we add IV ampicillin if listeria is suspected. In neonates, we give IV ampicillin plus gentamicin, and IV dexamethasone is given to reduce increased intracranial pressure. Definitive therapy is of course based on the culture and antibiotic susceptibility. Now coming on to the agents of this pyogenic meningitis, there can be pneumococcal meningitis caused by Streptococcus pneumoniae, pneumococcus, most common form of meningitis. Epidemiology is the leading cause of meningitis in adults more than 20 years and accounts for 50% of all adult cases. The location for this common cell is in nasopharynx and can spread locally to otitis due to otitis media or pneumonia. Hematogenous spread because of invasive disease, example meningitis bacteremia can be there. Now the virulence factors, capsule polysaccharide is the main factor. C, carbohydrate antigen, pneumolysine and autolysine are all the factors. Now the risk factors, underlying pneumococcal pneumonia. Obviously, if the organism is already there in the body in form of pneumococcal pneumonia, it can manifest as pneumococcal meningitis as well. Otitis media, alcoholism, diabetes, splenectomy, complement deficiency, and hypogammaglobulinemia, or head trauma and mortality, and head trauma, of course, these can all result in predisposition of the patient to pneumococcal meningitis. Mortality is high, 20% despite antibiotic therapy. Streptococcus has already been covered in previous chapter. Now, meningococcal meningitis is the second form of meningitis which we have to discuss here. The causative agent of this is Neisseria meningitidis meningococcus. It is a capsulated gram negative diplococci. So आपका जो क्वेश्चन फॉर्मेशन आएगा एग्जाम में केस में दे विल बी रिटन इफ देयर इज ग्राम पॉजिटिव और ग्राम नेगेटिव एंड द मॉर्फोलॉजी विल बी मेंशनड जिसके हिसाब से अकॉर्डिंग टू दैट यू हैव टू राइट योर आंसर्स. Now, lens shaped, half moon shaped, flattened adjacent sites, that's the morphology of the bacteria. And we can compare it with these both Neisseria variety, Neisseria gonorrhoeae, Neisseria meningitidis. Capsule is present in meningitis, absent in gonorrhoeae. Lens shaped, flattened lens shaped is Neisseria meningitis, while kidney shaped is gonorrhoeae. Sugar fermentation, glucose plus maltose are fermented by Neisseria meningitidis, while gonorrhoeae ferments only glucose. Plasmids are rare in meningitis but common due to drug resistance in gonorrhea, and form intra and extracellular forms of Neisseria meningitis are there, but gonorrhea is mainly intracellular. And habitat Neisseria meningitis resides in your nasopharynx, if so, okay, while Neisseria gonorrhoeae resides in the genital tract. Other Neisseria species are also there like Neisseria lactamica and Neisseria flavescens. These are common cells, occasionally pathogenic in immunocompromised persons. Now, the virulence factor for Neisseria meningitis, capsular polysaccharide is the main virulence factor. And this capsular polysaccharide is what protects it from the complement mediated phagocytosis. There are 13 serogroups A to D, X to Z, 29 E, W, H to J, and L. Invasive disease is caused by A, B, C, X, Y, W. Non-invasive or common cells are non-capsulated and other serogroups 16%. What are the other virulence factors of Neisseria meningitis? There is outer membrane protein called porins, liver polysaccharide and endotoxin is there, due to which inflammatory mediators are released and vascular injury is caused. Clinical features of meningococcemia are increased vascular permeability and shock. Intravascular thrombosis causes DIC, disseminated intravascular coagulopathy, and myocardial dysfunction can also precipitate. Now, it also releases IgA proteases, transferrin binding proteins, and adhesins. Regarding the epidemiology, the global burden is around 5 lakh cases a year. Mortality is 5 to 16%. Patterns are sporadic, endemic, hyperendemic, and epidemic. High prevalence zone is in sub-Saharan Africa, Ethiopia to Senegal, and almost 30,000 cases are annually reported. Serogroup distribution, epidemic reduced by vaccine, A reduced by vaccine, and B and C are the major current causes of worldwide cases. Group B is hyperendemic, more than 10 upon 1 lakh people, and group C outbreaks are there in Nigeria. X, Y, and W are less common, while W has been seen at mass gatherings like in Hajj 2000. About India, sporadic and outbreak cases mainly in North India are reported. Serogroup A is reported more than 12,000 cases in 2015, 8,000 plus from Bihar. Seasonality, winter and spring, cold, dry seasonality has been seen. And about age group, it's common in early childhood from 3 months to 5 years, while second peak is in adolescents from 15 to 25 years. The risk factors about this are the colonization risk, overcrowding, semi-closed settings, military schools, refugee camps are the risk factors. Travelers like Hajj pilgrims and smoking and recurrent upper respiratory tract infection all are at the risk for the disease. Also, some comorbid conditions or some other diseases can be there like terminal complement deficiency C5 to C9, therapy with eculizumab and ravulizumab, or hypogamma globulinemia or hyposplenism. All these 5 to 10% of the cases are asymptomatic carriers as well. Now, pathogenesis, natural host is humans only, and source is nasopharyngeal carriers of Neisseria meningitis. Transmission is by droplet inhalation, and then it leads to nasopharyngeal entry. and it spreads to meninges by hematogenous route, most common, direct via olfactory nerve, cribriform plate, and rarely via the conjunctiva. For the clinical manifestation, carriers majority are asymptomatic carriers, and symptomatic manifestations are rash, non-blanching petechial or purpuric rash, as we have already talked, are seen in meningococcal meningitis, seen in more than 80%. Septicemia can be there due to endotoxemia and vascular damage, and the patient can lead to septic shock. Waterhouse Fridolin syndrome is there, in which fulminant meningococcemia with large purpura fluminans, DIC, adrenal hemorrhage, shock, and multi-organ damage syndrome or dysfunction syndrome is seen, called as Waterhouse Fridolin syndrome. Pyogenic meningitis affects 3 to 5 age groups. Features are fever, vomiting, headaches, neck stiffness plus rash. We've talked about it. While chronic meningococcemia is rare, recurrent petechiae are seen, fever, arthritis, and splenomegaly is seen. Post meningococcal reactive disease is there, which is onset 4 to 10 days post infection, and immune complex diseases are the contributing factors like arthritis, rash, iritis, pericarditis, or polycerositis. Now, the lab diagnosis will see treatment for meningococcal meningitis, fatality rate untreated up to 50%, with early antibiotics less than 10%. What are the antibiotics used? Drugs of choice are third generation cephalosporin, ceftriaxone, or cefotaxime, like in bacterial meningitis for 7 days. Penicillin or alternative resistance reported in some areas. Supportive care, fluid resuscitation for shock, because as we have talked, patient can lead to septic shock, and measures to reduce intracranial pressure are applied. Prevention, chemoprophylaxis is indicated for close contacts, household, or direct exposure within 7 days before symptoms, regardless of vaccination status. About drugs, ceftriaxone single IM dose is the drug of choice, and rifampicin or ciprofloxacin are the alternatives. There are some vaccines for this as well. There are two types of vaccines: bivalent and quadrivalent. Bivalent A and C, quadrivalent A, C, Y, and W135. Schedule 3 to 18 months, two doses are given 2 to 3 months apart. Older children or adult, a single dose is enough. Efficacy is more than 95%, protection lasts for more than 3 to 5 years. Indications are outbreak contacts, splenic dysfunction, complement deficiency, eculizumab therapy, lab risk groups, and international travelers or students. There are some limitations in serogroup B vaccine as it is not available as a capsular vaccine. So there is poor immunogenicity. Capsule has sialic acid. Cross reactivity with neural cells is there, so it can be encephalotogenic. Okay, conjugated vaccines are given, protein carrier based. These improve immunogenicity and can be given to children less than 2 to 3 years. The vaccine group B, Men-B vaccine, is composed of 4 recombinant proteins: adenosine A, heparin binding antigen, factor H binding protein, and outer membrane vesicles (OMV). What the schedule 2 IM doses are given 1 month apart. Indication are the individuals aged 16 to 25 years. Okay, so this completes second. First was Streptococcus pneumoniae meningitis, and second was Neisseria meningitis. Now let us talk about Haemophilus influenzae meningitis. Epidemiology: previously common in children less than 5 years. Incidence reduced due to HIB, Haemophilus influenza B vaccine. The virulence factor capsular polysaccharide inhibits phagocytosis and is the main virulence factor. HIB serotype B is the most virulent, causes pneumonia, hematogenous spread, and can lead to meningitis. So this capsular polysaccharide is the main virulence factor which inhibits phagocytosis. HIB serotype B is the most virulent, causes pneumonia, which leads to hematogenous spread, and lastly causes meningitis. What are the clinical features? It's common in children less than 2 years, can lead to subdural effusion, can cause seizures or hemiperiasis. High mortality is expected if left untreated. Survivors suffer from neurologic sequelae like hearing loss or delayed language even after the treatment. there are some cases in which reduced expression is there. Group B, streptococcal GBS meningitis is there, caused by Streptococcus agalacti. Major cause of neonatal sepsis and meningitis it is. Types of neonatal disease: early onset from 0 to 6 days. Source is maternal genital tract during or before birth. Risk increases with prematurity or prolonged labor. Common are with pneumonia, RDS, sepsis, and meningitis. All these can occur due to this. Common serotypes are 1A, 3rd, 5th, 2nd, and 1B. CFR is 4.7%. Current fatality rate is 4.7%. Case fatality rate, sorry. Now, late onset 7 to 90 days. The source is colonized mother or nursing personnel. Common agents for meningitis and bacteremia. And common serotype is type 3 and case fatality rate is 2.8%. Treatment is with penicillin for 14 days, and if there is a shorter course, then there is a risk of relapse. Now, gram-negative bacilli meningitis occurs in chronic diseases like diabetes, cirrhosis, alcoholism, and in chronic UTI patients or neurosurgical patients with craniotomy or CSF leaks. Organisms attributed in gram-negative group are E. coli, Klebsiella, which cause neonatal meningitis, and Pseudomonas, which causes post-trauma or post-op meningitis. Acinetobacter is there, which causes post-neurosurgical meningitis, and Elizabeth Kingia meningosepticum causes neonatal meningitis. Now coming on to this exception, Listeria monocytogenes meningitis or listeriosis. Transmission is by contaminated food, coleslaw, milk, soft cheese, deli meat. Vertical transmission is there during delivery, survives refrigeration at 4 degrees Celsius, and risk increases with PPI use because due to pantoprazole and all, there is reduced secretion of gastric acid. So proton pump inhibitors are risk factor. At risk groups are neonates, pregnant women, elderly and immunocompromised patients. Pathogenesis, it is an intracellular surviving bacteria via Listeria O, and this lyses the phagosome and uses actin polymerization to move cell to cell. Listeriopods, that is called. Clinical manifestation: neonatal listeriosis results in early onset listeriosis, less than 5 days, average 1.5 days, acquired from maternal genital flora, associated with prematurity, low birth weight, and sepsis is most common. Granulomatosis infantiseptica is rare. Microabscesses are seen in skin, liver, and spleen. High mortality up to 50% is there. No nosocomial outbreaks are there. In late onset cases, more than 5 days, average 14.2 days duration. Environmental sources there, meningitis is most common. Nosocomial outbreaks are possible and mortality is less than 10%. In pregnant women, maternal flu-like illness is there, maternal symptoms, and bacteremia is there, and fetal complications can involve abortion, preterm labor, or neonatal sepsis. In adults, elderly, meningitis or bacteremia is common, and in immunosuppressed conditions, meningitis or gastroenteritis is again seen. Treatment is by ampicillin, gentamicin for 2 to 3 weeks, cotrimoxazole if allergic to penicillin, amoxicillin in febrile gastroenteritis, the risk patients. We have to avoid cephalosporins, chloramphenicol, vancomycin, linezolid, macrolides, and tetracyclines. Now coming to the last, staphylococcal meningitis caused by Staphylococcus aureus, coagulase negative staphylococci, occurs post neurosurgical procedure, especially in the ventricular shunting procedures. So with this we complete acute bacterial or the pyogenic meningitis part. Of course, the more important ones are Streptococcus pneumonia and Neisseria meningitidis. Listeria monocytogenes is important because that is an exception, because there is increased number of lymphocytes is there, and also it shows tumbling motility, so that can be a question. Other ones are the accessory topics. Now coming on to the last topic of this chapter, which is the chronic bacterial meningitis. Chronic bacterial meningitis is referred to as a persistent inflammation of the meninges lasting more than 4 weeks with persistent neurological symptoms and CSF abnormalities. What are the etiological agents? Partially treated pyogenic meningitis, parameningeal infections like otitis media, Mycobacterium tuberculosis, Borrelia burgdorferi, which causes Lyme's disease, and Treponema pallidum, which causes tertiary syphilis, are the etiological agents commonly related to chronic meningitis. Other rare organisms are Nocardia, Actinomyces, Strophairma vipili, Leptospira, or Brucella. The clinical manifestations are that the persistent headache and neck or back stiffness is there, hydrocephalus is common, cranial neuropathies like facial palsy, optic atrophy, hearing loss is there, myelopathy or radiculopathy of limb weakness, incontinence is there, and personality changes are there like altered sensorium, disorientation, memory loss. Specific agents of chronic meningitis, first being the tuberculous meningitis, important. TBM, pathogenesis, hematogenous spread of primary or post-primary TB is there, and basal meningitis with vasculitis and exudates are there. The clinical features, there is insidious onset with low-grade fever, headache, irritability, and progression to severe headache, confusion, cranial nerve palsy, especially ocular nerves is there, and complications involve hydrocephalus, vasculitic infarcts, coma. What about the CSF findings? Cells on TBM finding seen are 50 to 1000 per microliter, and lymphocytic cells about protein, it's high 100 to 800 milligrams per deciliter. Glucose content is low, and very important, very characteristic of tubercular meningitis is cobweb clot positive 12-hour standing tube. Okay, now the diagnostic test, AFB staining, acid fast bacilli show low sensitivity 10 to 40%. Culture shows gold standard in LJ medium 4 to 8 weeks, and in MGIT it takes 2 to 3 weeks for these to grow. Gene expert for MTB or RIF detects M tuberculosis and rifampicin resistance. MRI or CT can be done to see basal exudates or hydrocephalus, and CXR X-ray can be done to detect old TB lesions or miliary TB. Now, treatment is by antitubercular therapy. We know that HRZE therapy. Adjunctive steroids are given to reduce CSF pressure and reduce mortality. Early treatment reduces neurologic sequelae. Now, second type is neuroborreliosis or the Lyme's disease. Spreads by Borrelia burgdorferi via tick bite. CNS features appears after weeks or months. Bilateral facial palsy is seen with radiculopathy, meningitis, and Banwart syndrome is there, in which painful meningo uh, radiculitis is there, which is common in Europe and Asia. About CSF findings, lymphocytic pleocytosis around 100 cells per microliter, elevated proteins, normal or mildly reduced glucose is there. About treatment, IV ceftriaxone is given for 14 to 28 days, or IV penicillin G, cefotaxime is given. Third being the neurosyphilis, which can cause chronic meningitis, or the tertiary syphilis is there. Stages and features, 5 stages. First being the asymptomatic stage, in which there are changes only in CSF. Second up is the meningeal syphilis, in which chronic meningitis is there. Meningovascular stage, stroke due to arthritis is there. And in general paresis, psychiatric symptoms are there. Okay, and teres dorsalis, when it gets affected, it leads to posterior column demyelination, which can cause ataxia, bladder dysfunction. Now about the CSF findings, cells are more than 5 per microliter, lymphocytic cells are there, protein is more than 45 mg per deciliter, glucose is normal or mildly reduced. Diagnostic test, of course, for syphilis will be CSF VDRL, specific but low sensitivity, diagnostic if positive. FTA ABS test is done, which is more sensitive and useful if CSF VDRL comes negative. PCR technique detects Treponema pallidum genes, and treatment is by IV penicillin G 10 to 14 days. Desensitization for penicillin allergic patients. Retreatment if CSF VDRL titers don't drop fourfold in 2 years. Then we have to give treatment once more. Okay, so this was the topic of the whole bacterial meningitis, including acute and chronic bacterial meningitis. Now, there no, there it was written. Yes, there. General paresis. There is a mnemonic called paresis in which P stands for personality, A for affect, R for reflexes which become hyperactive, E for eye, which is affected eye sensorium. Okay. Uh, Example: Argyll, Robertson pupil are seen. S for sensorium, for illusion, delusion, and hallucination. I stands for intellect, recent memory loss, and S is for speech. Okay, so this was what was left. Now let us discuss some expected questions. ऐसे टाइप क्वेश्चन इज देयर जो आपके एग्जाम में भी केस आता है. A 7-year old girl with fever, headache, vomiting, seizure, and neck rigidity. So what was the most probable clinical diagnosis? Acute bacterial meningitis. Then it asks the etiological agent and pathogenesis. Etiologic agent based on age are Streptococcus pneumoniae, most common in children. Neisseria meningitidis, Haemophilus influenzae type B. Pathogenesis is that for this acute bacterial meningitis, there can be nasopharyngeal colonization, hematogenous spread, penetration to subarachnoid space, and inflammatory response is there due to increased permeability, cerebral edema, increased cranial pressure, and neurological symptoms. What we'll see in the CSF analysis, we see appearance of turbid WBCs more than 10,000 per microliter, neutrophilic, protein is high 100 to 500 mg per dl, glucose is low, less than 40 mg dl or less than 50% of the blood glucose. Gram staining, we identify the organism, example diplococci. In culture, blood and CSF, this confirms the diagnosis, and then we do latex agglutination which detects capsular antigens. Other tests can be blood culture, CRP, procalcitonin which supports infection, and PCR for specific detection, especially in the treated cases. So what will be the treatment modalities for Streptococcus pneumoniae infection, which is the most expected one in this case? There will be IV ceftriaxone or cefotaxime plus vancomycin. Okay, now Neisseria meningitis, we use IV ceftriaxone. For Haemophilus influenzae, again we use IV ceftriaxone or cefotaxime. Empirical therapy in child is IV cefotaxime or ceftriaxone plus or maybe not vancomycin. And adjunct therapy is dexamethasone before or with antibiotics. Next question is there. Alicia, 4-year-old with fever, Brudzinski sign, CSF shows gram positive diplococci with halos. So most probably this is a diagnostic of acute pyogenic meningitis, can be due to Streptococcus pneumoniae, which is gram positive lanceolate shaped diplococci with capsule and a clear halo. Okay, now the lab confirmation. CSF gram stain shows gram positive lancet shaped diplococci with capsule. In culture, we see Streptococcus pneumoniae on blood agar, alpha hemolytic colonies. We can do the latex agglutination test which detects capsular polysaccharide antigen of Streptococcus pneumoniae. Optogen sensitivity test we can do for Streptococcus pneumoniae is optogen sensitive. It distinguishes from virulent streptococci. Bile solubility test for Streptococcus pneumoniae is bile soluble, and PCR can be done because it detects pneumococcal DNA directly from CSF, especially useful if it is partially tested. Okay, so that is what is all about this acute meningitis or chronic meningitis, and this is a very important chapter. So after going through this video, please read the chapter from the book itself. Okay, so like, share, subscribe. Thanks for watching, and in the next video we'll be covering tetanus.